Okay, Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. I'm going to discuss today about diabetic nephropathy management updates, and this presentation will be based on the most recent guidelines published by KDIGO in 2022 for management of diabetic kidney disease. As we all know, that still chronic kidney disease, especially diabetic nephropathy, also is still underestimated, and only 10% of population with chronic kidney disease who are only diagnosed. Only 10% of patients who are actually having a chronic kidney disease is well known and diagnosed due to poor screening programs and missing of early stages of chronic kidney disease. This is to be compared to cardiovascular disease who are requiring statin therapy. On about 70% of patients are already diagnosed, and only 30% still missing. This is also to be compared to 80% diagnosis percentage in diabetic patients requiring treatment compared to another 20 still undiagnosed. So still the chronic kidney disease diagnosis is still very late, and we are missing many cases with early diabetic kidney disease or chronic kidney disease. And as you know, that diabetic kidney disease is representing 42% of cases with chronic kidney disease. Diabetes is very common cause for chronic kidney disease, while hypertension representing 18%, glomerular diseases representing another 18% of chronic kidney disease, and other causes represent 22%. So diabetes and hypertension representing more than 50% of causes for chronic kidney disease. According to Saudi Health Council in 2021, published that 42% of cases with renal failure are due to diabetes. And this is the leading cause for renal failure and requiring renal replacement therapy in Saudi Arabia. The next cause is, common cause is 34% is hypertensive nephrosclerosis. Other causes representing very minor percentage. The leading cause of chronic kidney disease and the progression to renal failure requiring renal replacement therapy, either by dialysis or transplantation, is mainly due to diabetes. And it is estimated that diabetes and hypertension during the last decade from 2010 to 2020 have doubled the number of cases with diabetes and hypertension in Saudi Arabia, according to the Saudi Health Council. This doubling significantly affects the number of cases with chronic kidney disease due to diabetes and hypertension in Saudi Arabia. And as we all know, that diabetes and chronic kidney disease are major risk factor for morbidity and mortality among this population. This population of diabetes and chronic kidney disease having 6 times higher risk of morbidity and mortality compared to normal population who don't have diabetes or hypertension. And this risk also in diabetics and chronic kidney disease is 3 times higher risk of morbidity and mortality compared to diabetics alone without kidney disease. Moreover, the risk is double, the morbidity and mortality double the risk in patient compared to patient with chronic kidney disease alone. So diabetes and hypertension and chronic kidney disease having the highest risk of morbidity and mortality compared to other population. And this is the journey of patient with diabetes. As mentioned by Dr. Osama before, diabetes and its complications start very early before the diagnosis. And at time of diagnosis, already the patient start having complication of diabetes and diabetic nephropathy. Due to persistent hyperglycemia before the time of diagnosis, patients are subjected to high glucose level, which leads to oxidative stress and cellular injury at the kidney level. And with this This is still increasing in the expansion of the mesangial matrix due to cell injury caused by hyperglycemia. And at this time, with cellular injury and mesangial expansions, there is disruption of the glomerular basement membrane, leading to higher GFR and starting protein leak with what we call it microalbuminuria at this stage, with associated normal creatinine level still, but already the injury already happened earlier before this stage. So here the patients are lost. We are missing patient at this stage when the creatinine only checked and it seems normal in the blood test. And we are missing sometimes because we are not ordering microalbumin testing. So these patients are lost in this stage. And this is our target, the screening, the early screening to detect patients early before having a significant finding, which is the rising of serum creatinine. With time and mesangial expansion, the more disruption of the glomerular basement membrane, microalbuminuria is increasing to macroalbuminuria, with the more urine albumin creatinine ratio increasing in urine, leading to progressive glomerulosclerosis due to inflammation and fibrosis of the glomerular capillary tuft. Glomerular sclerosis will decrease the functioning nephron mass, and this by time will lead to reduction of GFR, and here starts the rise of serum creatinine, at which we start picking patient when the creatinine is already start to appear. At this stage only, we are getting patients referred to nephrology with abnormal creatinine level. But where is the patient during this period? Is already missed. At this stage, when the creatinine rises, we are start looking for microalbumin or urine protein excretion. This patient during this period is missed by missing testing very simple urine test for urine albumin creatinine ratio. Very important to pick patient in this zone. With time progress more, the more proteinuria, the more tubulointerstitial fibrosis and more inflammation in the tubulointerstitial tissue, with more fibrosis and loss of the functioning kidney mass and more loss of GFR and rising of creatinine, as the patient ultimately progress to end-stage renal disease. With all these stages, there is hypertension that's ongoing and getting worse with time, while the patient losing his kidney function. With association of macroalbuminuria, there is increased risk of cardiovascular disease, which leads to many morbidity and leading to mortality. With also rise of the creatinine, we have association of kidney complication like renal anemia due to loss of erythropoietin production from the fibrosed renal tissue. And also patients start to have hypocalcemia, hyperphosphatemia, secondary hyperparathyroidism, and renal mineral bone disease as a complication of renal failure. So this is the time where we get patient referred, and this is the time we are losing by not ordering a GFR or simple urine test. So it's very important to pick the patient early in the disease before having rising creatinine. So whom to screen and how to screen and when to screen it. Patient with type 2 diabetes, we have to screen them 5 years, start screening after 5 years of diagnosis in type 1. And this will be later on yearly basis. While in type 2, at the time of diagnosis, we have to start screening for complication of diabetes as urine albumin creatinine ratio and GFR. At the time of the diagnosis of type 2 diabetes, not late. Start at the time of diagnosis and then yearly to pick up early cases. And how to screen? Simply, as we just mentioned, serum creatinine and estimated GFR, and a simple urine test for urine albumin creatinine ratio. No need for 24-hour urine collection, no need for any complicated tests, only just a urine sample for urine albumin-creatinine ratio and the GFR. And what to do if we have any positive result of this? We have to confirm before labeling the patient as a chronic kidney disease. We have to repeat the test again and to make sure that the patient having persistent rise of creatinine and persistent proteinuria, because some people having transient proteinuria that should be ruled out due to severe hypertension, severe hyperglycemia, or patients who are doing severe exercise before going to the urine test. So confirming the test is very important, and we do it at least to have at least 2 positive urine albumin creatinine ratio within 3 months to label the patient having persistent microalbuminuria and refer the patient or label the patient as a chronic kidney disease, regardless of his creatinine. And how to label the patient is, as I just mentioned, persistent urine albumin creatinine ratio above 30, with or without persistent GFR below 60, with or without ultrasound finding of chronic kidney disease, like small sized kidney, increased echogenicity, poor corticomedullary differentiation, all these findings by ultrasound, that according to which we can label the patient having a chronic kidney disease. So labeling the chronic patient with chronic kidney disease, persistent urine albumin creatinine ratio, persistent low GFR, or radiological finding by simple ultrasound. By this, we can pick up patient with diabetic kidney disease early. This is very important table, what we call it the heat map for chronic kidney disease in general, either diabetic or non-diabetic. And patients with chronic kidney disease are classified according to GFR or urinary albumin excretion or urine albumin creatinine ratio. According to GFR, classified to 5 stages from 1 to 5, and stage 3 is subclassified to stage 3A and 3B, while according to albumin creatinine ratio, it is A1, A2, and A3 from below 30 in A1, and A3 is above 30 milligram, 300 above 300 milligram per gram. Please take care of the units according to your labs. Patients are classified as low risk, moderate risk, high risk, very high risk. What's more important for me is the low risk patients in this area who are already still having normal creatinine, but their urine albumin creatinine ratio starting to increase. At this stage, this is a pickup point to pick patients with early diabetic kidney disease. This is very important in these 2 green squares. 2 more important squares is here. When the patient is still having normal creatinine in this area, can be presented as normal creatinine while GFR is still above 60. Patient is still having normal creatinine, but his urine albumin creatinine ratio above 300. This 300, we shouldn't consider it as a simple albuminuria of diabetic nephropathy. At this point, you see all these patients are labeled with screen, treat, 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 especially these 2, treat and refer. These 2 squares is very important. Why to refer to nephrology? Because at this number of high urine albumin creatinine ratio with a normal creatinine, we should rule out other causes of kidney disease. Because many patients, we see them at this stage and we find out that they don't have simple diabetic nephropathy, but they have underlying other glomerular disease like membranous nephropathy, minimally changed disease, focal segmental glomerulosclerosis. This is based on a kidney biopsy. So referring at this stage is very important, not to take the patient lightly as a diabetic nephropathy simply. So this is the important screen, these 2 squares and these 2 squares. And accordingly, other squares here, the red square, this is the time where to refer to nephrology. But these patients in these groups can be managed by internal medicine, by general medicine or family medicine, according to the guidelines that we are going to discuss later. So again, I confirm this is very important to screen area, and this is very important to rule out other causes of kidney disease rather than diabetic nephropathy. So to start the treatment of these patients, KDIGO guidelines in 2022 published this pyramid showing that we have to start with lifestyle modification and self-management like weight reduction, stopping smoking, regular exercise, and diet control. This is the basic education that should be given to the patient, and emphasize that this is the first step to educate the patient about it, and this is our target for this campaign for this year, as we just told. And the first line therapy recommended by the KDIGO for patients with diabetic nephropathy early stages is metformin for type 2 diabetes. SGLT2 inhibitors is now the first line therapy together with metformin. It's not a second line, it is a first line therapy due to its confirmed effect for protection of the kidney and cardiovascular outcome, as mentioned by Dr. Usama before. This is together with the maximum tolerated dose of RAS blockade to control hypertension, to reduce proteinuria, and reduce the progression of chronic kidney disease. In addition to statin, to control associated dyslipidemia, which is common in this group of patients. So this is the first line therapy. Patients should be screened every 3 to 6 months to update to evaluate the evaluation of the patient and to review his medication and to add on second line therapy if it is not controlled. Additional or second line therapy is GLP-1 receptor agonist for type 2 diabetes is a second line if patient is not achieving the glycemic control, and also antiplatelet for patient who already having confirmed atherosclerotic heart disease as secondary prevention. And the new era or the new line of management is the non-steroidal mineralocorticoid receptor agonist. This is a new line of treatment also to be added for patients with diabetes, chronic kidney disease, and having albuminuria. We are going to discuss in details later. Again, after 3 to 6 months, reassess to optimize the glycemic control, optimize blood pressure control, and optimize lipid management. If not well controlled with statin alone, we have to add on PCSK9 or ezetimibe for lipid management, and also glycemic control with other medicine after exhausting metformin, SGLT2 inhibitor, and GLP-1 receptor agonist. So we have to consider other lines up to using insulin. Blood pressure control after using the RAS blockade, the next lines will be calcium channel blockers, thiazide, beta blockers, all other stuff for blood pressure control. So this is the general map for management of diabetic kidney disease. First line is ACE inhibitor and ARBs. This is confirmed or recommended by the KDIGO guidelines 2021. And as we see here, it is recommended for patients with diabetes, hypertension, albuminuria, using the highest approved dose that's well tolerated. Maximum tolerated dose of ACE inhibitor or ARBs is very important to achieve it. How you achieve it? To start the patient with the lower dose and then increase gradually according to the patient tolerability. Patient tolerating according to his blood pressure. If his blood pressure is tolerating, we can increase with close monitoring of his serum creatinine and serum potassium according to the flow chart we are going to discuss now. As per the recommendation of the KD guidelines, we have to start ACE inhibitor or ARBs. This RAS blockade is very important to be monitored within 2 to 4 weeks of starting treatment. If the patient is showing normokalemia, we can also monitor the creatinine. If the increase in creatinine is less than 30% above the baseline, we have to continue ACE or ARBs or maximize the dose if the blood pressure tolerates. If the patient starts to develop hyperkalemia, we have to review. Before stopping the medicine, we have to review the current drugs. We have to advise about low potassium diet, consider other agents that might help for reduction of potassium, like diuretics, especially in patients who are having edema or heart failure, or can consider sodium bicarbonate, especially if the patient is having metabolic acidosis with chronic kidney disease, or start using the new potassium binders like patiromer or zirconium. These medicine can be used for lowering potassium and maintaining the use of ACE or ARBs because of their crucial benefit for such patients. The other concern here, if the creatinine is increasing more than 30% above the baseline after consuming or starting RAS blockade, we have to review again before considering stop or decreasing the dose. We have to review other causes of acute kidney injury that lead to increase the creatinine and assess the volume status of the patient having vomiting, diarrhea, using non-steroidal medication. All these can mislead you and increase the creatinine based on assumptions that the patient started ARBs. Some people might stop or decrease the dose of ARBs and lose the benefit of this medication. So we have to consider all management lines before changing or decreasing or stopping the dose of ACE and ARBs, because it is very important to have this line of management for patients with diabetic kidney disease. The value of ARBs in diabetic nephropathy was well shown in two major studies, the renal study and the IDENT study. It's very old study in 2001, and both showed the efficacy of losartan versus placebo with a 16% reduction in the progression of kidney disease to end-stage renal disease regarding losartan. Also, in the IDENT study, irbesartan was studied as a comparison with amlodipine or placebo, and in both arms, the irbesartan showed significant effect with reduction of progression of kidney disease and compared to placebo and also in amlodipine. So in these two studies, losartan, irbesartan have shown a proven efficacy in reduction of progression of chronic kidney disease among diabetic patients. After ACE and ARBs, the second line is SGLT2 inhibitors. And this is very important group of medicine in the era. It's not just a diabetic medicine, it's not just a heart failure medicine. It is now recommended for treatment of chronic kidney disease, either due diabetes or non-diabetic chronic kidney disease. And as per the recommendation of the KDIGO in 2022, we recommend treating patients with type 2 diabetes, chronic kidney disease, and eGFR. Now it is down to 20 milliliter per minute with SGLT2 inhibitors. So we can use SGLT2 inhibitors according to these guidelines down to a GFR of 20. Previously it was on 45, now down to 30. Now we are down to 20 according to the most recent recommendation. So enhancing the use of SGLT2 inhibitors among patients with diabetic kidney disease. But we have to be careful when we start using this medication. We have to properly assess the patient and the patient eligibility, as we just mentioned, as GFR more than 20 milliliter per minute. And patient with high priority if he's having uncontrolled albuminuria after using ACE or ARBs. And patient with heart failure, all these population will get maximum benefit of SGLT2 inhibitors. And the potential contraindication is not an absolute contraindication. If the patient having recurrent genital infection, diabetic ketosis, foot ulcer, or patient who are on immunosuppression like kidney transplant. This is the general recommendation for patients. But we have to make sure that the patients who are at risk of hypoglycemia, especially those who are on insulin or sulfonylurea, patients should be well educated about the risk of hypoglycemia, and probably we will consider reviewing the dose of insulin and sulfonylurea in such patients to avoid development of hypoglycemia. Another point to take care of is a volume status assessment for patients who are going to use SGLT2 inhibitor is a volume status assessment. Patients who are at risk of hypovolemia, especially old, frail patients, or patients who have a history of acute kidney injury before, or patients who are using concomitantly diuretic therapy, these patients should be thoroughly evaluated to assess the patient volume status and avoid volume depletion in such patient, warning the patient and educating the patient about this issue. And probably we might review or withdraw the dose of diuretics in some patients. As we all know that SGLT2 inhibitors are acting on the proximal convoluted tubules. This is a patient with diabetic nephropathy or diabetic nephron who, in this group of patients that are having hyperglycemia, more glucose and more sodium reaching to the proximal convoluted tubules that's well absorbed to the interstitium, and less sodium is reaching the macula densa here, that is sensed as the macula densa, resulting in vasodilation of the afferent arteriole in the glomerulus, increasing the blood flow into the glomerulus, increasing the intraglomerular pressure, and progressively by time leading to glomerular sclerosis, that is underlying pathology for diabetic nephropathy. So this is the diabetic patient. If we are instituting here the SGLT2 inhibitor, it will block the reabsorption of dextrose and sodium in the proximal convoluted tubule, allowing more sodium to reach the distal tubule or reaching the macula densa. This will be reflected on the afferent arteriole, causing constriction of the afferent arteriole, reducing the blood flow going into the glomerulus and reducing the intraglomerular pressure. That's why it decreases the albuminuria and decreases the progression of chronic kidney disease by reversing this process of glomerular sclerosis. So SGLT2 inhibitors have important hemodynamic effect here at the level of the glomerulus by decreasing the inflow of blood to the glomerular capillary bed and decreasing the intraglomerular pressure. So it's a hemodynamic effect to the kidney. This is to be compared to the RAS blockade. As we just mentioned, SGLT2 inhibitors acting on the afferent arteriole going to the glomerulus, reducing the size of the afferent arteriole, reducing the intraglomerular pressure, reducing albuminuria, and this will lead to prevention of progression of chronic kidney disease. This is to be compared to the RAS blockade. They are acting on the efferent arteriole. They cause dilatation of the efferent arterioles, opening the outflow of the glomerulus. That's reflected on the intraglomerular pressure by reduction of intraglomerular pressure and reducing albuminuria, reducing the progression of chronic kidney disease. So SGLT2 inhibitor acts here, RAS blockade acts here. And combining both together in patients with diabetic nephropathy has beneficial effect in reducing the intraglomerular pressure significantly, which might, as the start of treatment, combining both medicine together, might be reflected on the serum creatinine. We notice sometimes that the patient having a serum creatinine rise slightly after the start of the SGLT2 inhibitors. This will be auto-regulated later on, and the patient will show again reduction again to the GFR, the creatinine level to the baseline before starting the SGLT2 inhibitors. That's why we are advising not to stop SGLT2 inhibitors if we have initial rise of serum creatinine, especially within the first to 3 months after starting treatment with SGLT2 inhibitor. SGLT2 inhibitors, we have 3 major molecules, is the canagliflozin, empagliflozin, and dapagliflozin. All of them are included in major trials to prove the cardiovascular outcomes for canagliflozin included in the CANVAS study, which included about more than 10,000 patients with established cardiovascular disease and having a GFR more than 30. These group of patients having a primary endpoint in this CANVAS study, having a primary endpoint of the MACE and showing reduction of this primary endpoint by nearly 22%. But in the secondary endpoint is a composite endpoint, renal endpoint, which was defined by reduction of serum creatinine more than 40% below baseline, or reaching the patient's stage of renal replacement therapy and renal death. And it showed a reduction by relative risk reduction by 40% for canagliflozin. This is to be compared to the empagliflozin study included more than 7,000 patients. Most of them, or all, nearly all of them, are having established cardiovascular disease, and their GFR at baseline was more than 30%. And they showed a significant reduction in the primary endpoint of MACE, that's about 14%. And regarding the renal endpoint, it showed a relative risk reduction by 46% regarding empagliflozin in the EMPA-REG initial trial. This is to be compared also to dapagliflozin. The DAPA or the DECLARE study included 17,000 patients, 41% with established cardiovascular disease, but their selection of patient was cutoff GFR more than 60 milliliter per minute, and their reduction of the primary endpoint was around 7%, to be compared to the composite renal endpoint, which is about relative risk reduction of 47%. So these three studies, as was originally designed as a cardiovascular outcome trials, and showed as a secondary endpoint reduction of the secondary endpoint by 40% for cana, 46% for empagliflozin, 47% for dapagliflozin. The most recent updated trial is the EMPA-Kidney trial that's recently published in the New England Journal of Medicine on November 4, 2022, less than 1 month. It is already published, and this study was designed to assess more patients with chronic kidney disease, either diabetic or non-diabetic patients who are having a worse kidney function. Remember, in the EMPA-REG trial, the cutoff GFR was 30% and above. Here, the target was more than 20 milliliter per minute of GFR and above. It is an randomized controlled study, and here they only used empagliflozin of 10 milligram, while in the EMPA-REG was 10 or 25 milligram of empagliflozin. This study used only EMPA 10 milligram once daily with another arm of placebo. And the inclusion criteria was a GFR above 20 milliliter per minute and albumin creatinine ratio more than 200 milligram per gram. With a composite primary outcome is a cardiovascular or renal death, maintenance patient reaching maintenance hemodialysis or requiring kidney transplant, or sustained reduction of GFR below 10 milliliter per minute. This is the inclusion criteria and the endpoint. And the patient characteristics, patients including was about 6,600 patients with a mean follow-up of around 2 years. And the GFR at average was 37.5 milliliter per minute. And urine albumin creatinine ratio is a median of 412 milligram per gram. And the primary renal diagnosis of the patients included only 1/3 of population are diabetic nephropathy, while the remaining 2/3 are other renal disease. Only 1/3 are due to diabetic nephropathy. So they are studying the effect of empagliflozin in diabetic kidney disease and non-diabetic kidney disease, and other comorbidities associated for patients diabetes or cardiovascular disease. Results of this study showed that progression of kidney disease was reduced by 28% among patients with chronic kidney disease included in this study. The progression, the hospitalization for heart failure or cardiovascular death was reduced by 16%, and hospitalization for any cause was reduced by 14%. So it's a significant reduction for delaying progression of chronic kidney disease. Among patients with chronic kidney disease, 2/3 of them are non-diabetic, with a proven efficacy of this medicine for reduction of chronic kidney disease or reduction of progression in non-diabetic chronic kidney disease. The other major trial designed for chronic kidney disease is a DAPA-CKD trial, which included more than 4,300 patients with chronic kidney disease. Here, only 1/3 are not diabetic, and 2/3 are diabetic. In comparison to the EMPA-Kidney, here are more diabetic population, 1/3 only is not diabetic. And according to their results, they showed a 39% relative risk reduction for the composite endpoint of the kidney regarding the development of end-stage kidney disease, worsening or sustained reduction of GFR, or cardiovascular and renal death. And to be noticed that out of this 39%, here 36% relative risk reduction in patients with type 2 diabetes. And patient without type 2 diabetes, the relative risk reduction was 50%. So this is also confirming the efficacy of this medicine for reduction of progression of chronic kidney disease among non-diabetic population in addition to diabetics. And in comparison here, the DAPA-CKD included 4,300 patients. The EMPA-Kidney included 6,600 patients, and it is recently released in 2022, November. And here, the DAPA-CKD was released in 2020. Inclusion criteria here was GFR above 25 milliliter per minute, compared to the EMPA-Kidney included patient with a GFR down to 20 milliliter per minute. So including more worse kidney disease among those patients. And the results as a primary outcome showed relative risk reduction by 39% in the dapagliflozin compared to placebo groups. And in the EMPA-Kidney trial showed a 28% relative risk reduction of the primary kidney endpoint. And this was significant reduction among patients with type 2 diabetes and also non-diabetic chronic kidney disease. So now we discuss the value of using SGLT2 inhibitors in patients with diabetes and non-diabetes, and its proved efficacy in all patients with type 2 diabetes or non-diabetic patient. And before also, Dr. Osama highlighted the value of using this group of medicine in heart failure patients and also for diabetic patients. So it is not just a medicine for diabetics or for heart failure or diabetic nephropathy, but also proved of efficacy in non-diabetic chronic kidney disease. And this is a minor study that published in 2019, it's called an Oslo study. They tried to prove the efficacy of this medicine in patients with kidney transplant, because as you remember, we already mentioned that one of the potential contraindication to use SGLT2 inhibitors is immunosuppression. And as we all know that patients with kidney transplant are immunocompromised, and they included 49 patients, 24 are treated with empagliflozin, and placebo group is 25 patients. And the outcome of this study shows that the A1C reduction in this group of patients was only minus 0.2% of patients after use of empagliflozin. And if the starting A1C was above 8, the reduction was more significant to 1 of A1C. And also they noticed that the greater response or the greater reduction of A1C was noticed in patients with a GFR more than 60 milliliter per minute. At the same time, they showed additional benefit of empagliflozin in this group of patients, as there is a weight reduction about 2.5 kilograms. A mean blood pressure was not significantly changed. Uric acid reduction in this group of patients. This is important for patients with kidney transplant who are using immunosuppression with CNI that increase the uric acid. So this also an add-on effect or beneficial effect on this population with kidney transplant, reduction of uric acid. Also, hemoglobin level is increased by 0.5%. This is also an add-on benefit of using SGLT2 inhibitors in patients with kidney transplant. But definitely we cannot use this as a standardized treatment because it's only a minor study and only 49 patients included. And the duration of this study was only 6 months. But also it confirmed the efficacy of SGLT2 inhibitors in this group of patients without noticeable urinary tract infection incidence. Was only 2 patients during this period of 6 months having a urinary tract infection and urosepsis. And still it can be used, but cannot be to the level of guidelines. So now we saw that SGLT2 inhibitors used in many areas, and we don't know what's hidden in the future. So all doctors are using now SGLT2 inhibitors are called flozzinators. So are you a flozzinator now, or still we didn't start or afraid to start using this group of flozzins? Now we discuss the ACE or RAS blockade. We discuss the SGLT2 inhibitors. Now the GLP-1 receptor agonist in treatment of diabetic nephropathy, and its value according to the KDIGO guidelines 2022 to be instituted for patients with diabetes and chronic kidney disease who didn't achieve a glycemic target, because it didn't show any significant value in reducing the progression of chronic kidney disease according to the trials. Only it shows a significant reduction in the A1C level to achieve the glycemic target. And also it showed some effect for reduction of urine protein creatinine ratio. And this is to be compared to SGLT2 inhibitors. GLP-1 didn't show any significant value for patients with diabetic kidney disease, except for reduction of albuminuria. And that's why it is only recommended for patients who didn't achieve the glycemic target after using the standard therapy of metformin and SGLT2 inhibitors. The last line, and not the least, that's starting now as a new guideline, is a non-steroidal mineralocorticoid receptor agonist. According to the KDIGO guidelines, they are recommending the non-steroidal mineralocorticoid receptor agonist with a proven kidney and cardiovascular benefit for patients with type 2 diabetes, especially those who are having a GFR more than 25 milliliter per minute, normal serum potassium, and albuminuria, despite the use of a maximum tolerated dose of RAS blockade. So again, we go to square zero. RAS blockade is the first line, and if not enough to achieve reduction of albuminuria, we can add the non-steroidal mineralocorticoid receptor agonist. And why we start thinking of this line of treatment? Because all studies for ARBs, SGLT2 inhibitor, after all this reduction of risk of progression in diabetic patients with chronic kidney disease, still there is residual risk for progression after using RAS blockade, after using SGLT2 inhibitors. Still there is a risk of progression to chronic kidney disease reaching to end-stage renal disease. Why is there still risk of progression? Because we already targeted two factors of the drivers of chronic kidney disease in diabetic patients. We are targeting now hemodynamic effect by using RAS blockade, thiazide diuretics, calcium channel blockers, SGLT2 inhibitors. This will correct the hemodynamic driver of chronic kidney disease. And the other driver is the metabolic effect by using SGLT2 inhibitors, GLP receptor agonist, metformin, other anti-hypoglycemic agents. All these tackle the metabolic driver. But still we are missing another driver, is the inflammation and fibrosis in the kidney tissue that's responsible for development of progression of chronic kidney disease reaching end-stage renal disease. In this study, it was shown that fibrinogen and TNF-alpha levels are higher among patients who are at higher risk of progression and decline of GFR more than 50% after a follow-up trial of 2 years. And these levels of fibrinogen and TNF-alpha are pro-inflammatory and pro-fibrotic factors, and it's found it's in the highest level among patients with having higher percentage of reaching this primary point of progression or decline of GFR more than 50%. This is to prove that there is another part of the pathophysiology of diabetic nephropathy is fibrosis and inflammation of the renal parenchyma. And it is postulated that it is due to mineralocorticoid receptor overactivation among these patients, which increase the expression of the pro-inflammatory cytokines and pro-fibrotic mediators, which lead to inflammation and fibrosis. This will result in kidney damage, vascular damage, and cardiac impact by cardiac fibrosis or cardiac hypertrophy at first. So inflammation and fibrosis due to mineralocorticoid receptor overactivation will lead to these damages, which are irreversible damage due to inflammation and fibrosis. So to stop this, we know all that aldosterone is an important factor in progression to hypertension, renal fibrosis, and development of chronic kidney disease, and also for heart failure. To stop this process, mineralocorticoid receptor antagonist that we all know is the spironolactone or eplerenone, all are steroid molecules that have a potency regarding the mineralocorticoid receptors, high potency to bind it with less selectivity. This means that it can bind another steroid receptors like hormonal receptors. That's why these two molecules having sexual side effects like gynecomastia that we usually notice with using spironolactone, and it have an active metabolite and have a major effect on blood pressure reduction. So the side effect of spironolactone is the potency, so as mineralocorticoid receptor antagonist to bind it, and having poor selectivity to the receptor, having sexual side effect and a high effect on blood pressure. The new molecule is a non-steroidal molecule, is finerenone. Finerenone is a non-steroidal mineralocorticoid receptor antagonist and having a high potency for binding the mineralocorticoid receptor, and it is a non-steroidal, so it doesn't bind the other steroid hormones. That's why it doesn't have any sexual effect as gynecomastia and has a minimal effect on blood pressure. So its value as a mineralocorticoid receptor antagonist is a minor effect on blood pressure, no sexual side effects, and having a high potency, high selectivity for the binding the mineralocorticoid, and by which will overcome the mineralocorticoid receptor overactivity, leading to reducing the fibrosis and inflammation in the tissue. And this is a postulated mechanism of, or confirmed mechanism of finerenone after binding it, having a proven inflammatory and fibrosis effect reduction and a minor hemodynamic effect on the kidney. That's all protecting the kidney and the heart from the mineralocorticoid receptor overactivation. Finerenone was included in two major trials, is the Fidelio trial and Figaro trial. This trial was designed for patients with late stages of chronic kidney disease and diabetes for confirming the role of finerenone in reduction of renal failure among patients with chronic kidney disease and diabetes. And Figaro trial was designed to confirm the effect of finerenone in reducing the cardiovascular morbidity and mortality. These two trials are later on pooled in one pooled analysis called the Fidelity pooled analysis. And they included a very big number of patients, more than 13,000 patients included in this trial, in the Fidelity pooled trial. The study was designed for patients with type 2 diabetes, chronic kidney disease, with maximum tolerated dose of RAS blockade. It's very important. All patients are subjected to this treatment together with maximum or basal maximum treatment for type 2 diabetes, including SGLT2 inhibitor, GLP-1 receptor agonist, all this treatment for targeting glycemic control and targeting blood pressure control for RAS blockade. And patients are kept in run-in period up to 16 weeks, and then screening. And then patients for the Fidelio DKD trial included 5,700 of these patients divided in two arms, 1-to-1, finerenone treated group or placebo treated group. Finerenone either 10 or 20 milligram every day according to their GFR and followed up for a period of 2.6 years. And the primary endpoint with the kidney composite endpoint is a time to renal failure, sustained more than 40% reduction in GFR below the baseline or renal death. Other endpoints is a cardiovascular or other renal, non-specific endpoints. But what's important for us is the kidney composite endpoint. The overall summary and conclusion for this study, it showed a risk reduction of progression of chronic kidney disease by 18% in a pool of patients of 5,000. And the risk reduction of cardiovascular morbidity and mortality was 14%. Finerenone was well tolerated in the Fidelity pooled analysis. It shows that the reduction of blood pressure among the 14,000 patients was average 3.2 millimeter of mercury, which is not having a significant hemodynamic effect leading to cessation of treatment, have no sexual side effects as gynecomastia, and also the risk of hyperkalemia that we are afraid of in patients receiving mineralocorticoid receptor agonist is very minor and rarely lead to stop of medication. And it showed that the median or the mean increase of serum potassium after use of finerenone is 0.23 millimole during a 4-month period of follow-up compared to the placebo group. So it's a minor increase in the serum potassium. But still in the Fidelity pooled analysis of 14 patients, it shows that 14% of patients having hyperkalemia compared to 6.9% in the placebo group. And only 1.7% had significant hyperkalemia leading to cessation of treatment. Only 1.7% out of 14,000 patients had hyperkalemia, which is non-significant in this study. That's why they recommended a management strategy to minimize the impact of hyperkalemia, that to start finerenone should be guided by the GFR. If the GFR below 60 milliliter per minute, we should start with 10 milligram once daily. And if the GFR more than 60, we can start with the 20 milligram once daily, provided that the serum potassium is less than or up to 4.8 millimole per liter. And we can continue treatment even with rise of potassium up to 5.5. It is safe to continue using finerenone. If patient having a serum potassium more than 5.5 after use of finerenone, we have to stop temporarily the finerenone and restart the treatment with a lower dose, 10 milligram once daily until the serum potassium drops below 5, then we can resume the phenrenon at a lower dose. In the study, it is noticed that subgroup analysis in the Fidelio trial that patients are originally diabetics and having treatment for diabetes with SGLT2 inhibitors. And this group of patients, they have sub-analysis for the urine albumin-creatinine ratio in this patient group. And the reduction was 32% of urine albumin-creatinine ratio below the baseline of urine albumin-creatinine ratio in patients who are not treated with SGLT2 inhibitors. But in patients with SGLT2 inhibitor started at baseline, having only 25% reduction of urine albumin-creatinine ratio below the baseline, which means that the reduction of proteinuria here is not only attributed to SGLT2 inhibitor, but also to the add-on effect and the beneficial effect of phenrenon in reduction of protein excretion or urine albumin-creatinine ratio. Moreover, the subgroup analysis that patients who are receiving SGLT2 inhibitors showing a significant effect in the reduction of, improvement of kidney outcome and cardiovascular outcome. So combining SGLT2 inhibitors and phenrenon have an add-on effect for cardiac outcome and renal outcome. That's why phenrenon is now part of the new recommendation of the American Heart Association for prevention of cardiovascular disease, also included in the American Diabetic Association guidelines for chronic kidney disease reduction, again for cardiovascular risk reduction recommended by the American Diabetic Association. Sorry, it's long. Huh? So take-home message that's the new recommendation in 2022, having all the initial recommendation in 2020, but the changes are included here is the SGLT2 inhibitor, as we mentioned before. In 2020, the recommendation to use SGLT2 inhibitor down to a GFR of 30 milliliter per minute, but the new recommendation 2022 recommending using in type 2 diabetes and chronic kidney disease with GFR down to 20 milliliter per minute. The added new recommendation in 2022, which was not there in 2020, is the addition of the mineralocorticoid receptor antagonist in patients with type 2 diabetes, GFR more than 25, and normal serum potassium, especially with albuminuria more than 30 milligram per gram. And the other recommendations are the same. And to summarize, this is a guideline for patients with either type 2 diabetes only or type 1 and type 2. Here is a lifestyle modification. First line treatment, as we discussed, the SGLT2 inhibitor down to 20 milliliter per minute GFR, metformin down to 30 milliliter per minute, and in addition to RAS blockade to the maximum tolerated dose, and statin for cardiovascular risk reduction. Additional risk-based therapy, GLP-1 receptor agonist for those who are not achieving the glycemic target. Non-steroidal mineralocorticoid receptor antagonist, if albumin-creatinine ratio more than 30, still persistent proteinuria in a patient with GFR more than 25, then we can add on the phenrenon. Other glucose-lowering agent to achieve more glycemic targets is very important. For other risk factors, antiplatelets should be instituted for patients with established atherosclerotic cardiovascular disease. Antiplatelets like aspirin, other antihypertensive to achieve the target blood pressure. Adding ezetimibe or PCSK9 inhibitors is also to be added for patients with severe uncontrolled dyslipidemia. If blood pressure is still uncontrolled, then we can resort to steroidal mineralocorticoid receptor antagonist, which is aldosterone, that we don't prefer if the patient having a GFR below 45 milliliter per minute due to high risk of hyperkalemia. To summarize, this is the 4 pillars of diabetic kidney disease as a lifestyle modification and metformin as the standard of therapy. Maximum tolerated RAS blockade for patients with chronic kidney disease, provided that the maximum tolerated according to their blood pressure, and the newly added SGLT2 inhibitor